in Public Health at HESRi, Investment in Health and Wellbeing Collaborating Centre, which is part of Public Health Wales. And I want to welcome you to this event today, which is a webinar, part of European Public Health Week on influencing the health gap. And I'm really excited to have a lovely range of speakers today from Wales, Italy and Slovenia that are giving us insight and have some discussion on the use of the decomposition analysis methodology and its future use. In particular, I'd like to thank the Regions for Health Network and the Public Health Network Cymru for all their help supporting this webinar, and also for Alvis Borsellini and Lauren Cousins, who have put in a lot of work behind the scene. So thank you. And I'm really looking forward to having a really in-depth discussion after some really brilliant presentations from our speakers. Just a few little housekeeping things to talk about. So after we have our presentations, you'll be able to ask questions, and if you just put those in the chat, and then we'll try and tackle as many of those questions as we can, which will go to the panel. And you're very welcome to do these questions in English or Welsh. And also to let you know that this webinar is being recorded and it will be available afterwards on the Public Health Network Cymru website. If you do have any technical difficulties during the presentation or during the webinar, if you could just flag those in the chat at the side and one of our team will try and help you. Helen Keller wrote that the welfare of one is bound up in the welfare of all. And I think particularly at the moment with our cost of living crisis, this is especially true. And the gap between those who have and those who have not is widening. So there's a gap between those who are most deprived and least deprived. And the decomposition methodology is a really innovative way to better understand what is driving that health gap and to identify the interventions and policies that will have the maximum impact to provide solutions for health inequalities. So we're hoping today we'll have further insight and discussions on how we can use this methodology in different ways in different countries and to learn from each other from these experiences. I'm going to introduce to you Dr. Bettina Mene, who we have the pleasure of having in our company today, who's the coordinator of the Regions for Health Network and the WHO European Office for Investment in Health and Development. And we welcome you, Bettina. I think you're going to say a few words.
Yeah, thanks very much, Jo, and thanks for everybody attending and to the speakers. First of all, I would like to thank on behalf of the WHO Regional Office for Europe and the Venice office, and on behalf of the Regions for Health Network, everybody who is here. In particular, also one thing goes to the Emilia, the participant from Emilia, because as you well know, or you might have heard, unfortunately, Emilia has been affected by severe flooding with more than 36,000 people homeless, and at least, if I got it right, 15 casualties. So thanks, Luigi, for participating, even though it's not a bright day. So what is the Regions for Health Network? It is 34 regions coming together from 26 European countries, stretching from Turkmenistan to Spain, with members who have at least 18 million of inhabitants up to a few thousands of inhabitants. So what do we aim for? We aim for promoting health and well-being at all ages across the sectors and settings, secure universal access to high-quality care without financial hardship, protect against the health emergencies, and power health through science, data, and innovation. And this is where the 34, on these aspects, the 34 regions are working together. Having said this, in 2019, our office launched the Health Equity Status Report Initiative, the so-called HESRi, with the main aim to support European policymakers in promoting health for all and reducing specifically the health inequities. In 2020, Italy adopted this approach and in collaboration with us, embarked upon a national assessment of health equity and well-being. Therefore, today, I'm also grateful, besides Wales and the Slovenia joining us, that we will have 3 Italian regions Emilia-Romagna, Lombardia, and Veneto, who will be telling us a little bit more about what they actually did and what is forthcoming. So now, and of course, we have the Istituto Superiore della Sanità present, who has been supporting this work and the Regions for Health and the whole of the WHO since many, many years. So with this, I hope that this information you will be getting today will be very helpful and that we will be continuing our cooperation in the months and years to come. Thanks very much.
Thank you. And we're now going to hand over to James Allen, who's the Principal Public Health Intelligence Specialist, who's now working at Population Health Bristol, North Somerset and South Gloucestershire. Thanks, James.
Thanks, Jo. I'll just get my slides up one moment. Hopefully everybody can see those. So yeah, thanks for inviting me here today. I'm going to give a bit of a Welsh angle on this as to how we conducted the decomposition analysis. I'm going to be talking about what prompted us to undertake the work, a little bit about the report, some of the key messages falling out of the report, the methodology itself, and really asking the so what question and looking forward, what can we do? Bettina mentioned in her speech the European Health Equity Status Report. I think we saw this in the WHO Collaborating Centre and thought we really want to replicate something like this on a Welsh footprint. We thought it was quite unique in nature and being able to see the relative contributions of the determinants of health or the essential conditions as they're framed here to the health gap was quite a powerful tool, especially in the policy space. So these are a few outputs from the European level report, but yeah, we had a strong desire to do something at a national level or a Welsh level, shall we say. So about our report, so the purpose, it was mainly to inform policy action, but also to generate insight into the drivers of health inequity in Wales. We explore the challenges, lessons learned, opportunities. We were quite upfront also that this was quite a big learning opportunity for us. We didn't really know much about the blind Oaxaca decomposition before embarking on this work. The context that we were working in, so Wales is a live innovation site for health equity. We have a memorandum of understanding between the WHO Regional Office for Europe and the Welsh Government, very much focused around investment towards closing the health gap. And we also have, I guess we have quite a fortunate policy context. We have the Wellbeing of Future Generations Act, socioeconomic duty. So there's quite strong links between what we call the Welsh Health Equity Status Report Initiative and the policies we have in place. The scope of our work, so we provided a snapshot of inequities experienced in the years leading up to COVID-19. We looked at 3 measures of self-reported health. So we looked at the prevalence of fair or poor health, the prevalence of low mental well-being, and the prevalence of low life satisfaction. We compared these prevalences between 2 different groups of people then, and they were defined by people's ability to save, whether they were in material deprivation, and whether they had a limiting long-standing illness. Who is our audience? Who are we targeting the work towards? Very much public health professionals, policymakers, analytical colleagues, but also anybody with a role, anybody whose role it is, to reduce the health gap in Wales and beyond. The key messages falling out from the work, so probably not a surprise, but significant health gaps existed between different population groups. And the decomposition analysis did generate new insight to the drivers of health inequity. We found social and human capital and income security and social protection accounted the most for health gaps observed, and this was in the majority of health outcomes. We also found that health services accounted the least I probably don't have enough time to do the methodology enough justice, but basically the Blind-Hacker decomposition breaks down the gap into a component that we can explain due to differences in the levels of the determinants, and a component that we can't explain, which is usually down to unobserved factors included in the model. It's a demanding methodology, so it requires a single individual level data set containing variables covering outcomes, health outcomes, but also determinants of health and stratification factors. This is just to show how really the report and the work that we've done is a combination of both methods from the economic literature and the framework which has been provided by the WHO Regional Office for Europe. What data source did we use? So we used the National Survey for Wales. We're quite lucky in Wales to have this. It's an annual survey and it covers a broad range of topics. I won't run through all of them, but just to mention a few: population health. It has good coverage of the wider determinants in there. It's also a random sample and around 12,000, I believe, individuals surveyed a year. For the period in which we analysed, the survey was conducted via face-to-face interviews. I'm not going to go through all this in detail, but this just gives a bit of a feel for the variables that were used as proxies for the essential conditions. Social and human capital had good representation. So, for example, education, volunteering, trust in the community and whatnot, but there were areas that were much weaker. Health services, we did struggle. Yeah, so just to be transparent about that. This is an example output. We got many outputs in the report, but this basically looks at the gap in the prevalence of fair or poor health between those who were able to save £10 a month and those who were not. I should say we were very much dictated by what data was available to us. But here, for example, we can say that 15.3% of people who were able to save £10 a month report fair or poor health. This is compared to 26.8% in those who are not able to save £10 a month. How is this gap broken down? Well, we can explain 45.5% of it. And when we drill down further, we can really see that social and human capital in purple and income security and social protection are highly influential in that gap. So it's quite nice from a policymaker perspective to then look as to what levers can be pulled to try and achieve change. So what? We've found the outputs really useful actually when triangulating with expenditure data. I think it's quite useful to identify alignments or mismatches and making that case for investment. Yeah, so on the left, fair or poor health, and on the right, we have expenditure in Wales in the year 2019-20. Looking forward, so it's quite clear to us that future policy and investment decisions should prioritise the mitigation of the drivers of health inequities, and interventions really should not be planned in isolation. We're very aware that we haven't tapped into the COVID-19 impact or cost of living impact with our work, but it's something that I think we would have an ambition to do. But we also really see the value in the capacity building element. We're keen to share our work and we are keen to learn if we're doing something that could be improved too. All our work lives in the public domain. I've included the links. We're really keen to share our work in the academic space too. So we have got a paper. We've got an interactive tool to explore the data sitting behind the work. And yeah, I'm not going to pretend I've done all this work by myself because I absolutely have not. It's quite a large team sitting behind this work on the screen at the moment. And yeah, it's an absolutely collaborative piece of work, and I don't think it could be achieved without anybody on the screen right now. Big thanks to Lynn Yang and Luke Munford really helping with the technical components. and also the HESRi, Welsh Health Equity Status Report Initiative scientific and advisory group contributors. That's all from me. I'm going to pass over now to Dr. Luigi Bertinato from the Office for International Health and Social Affairs to give the perspective from Italy. So I'll pass over. Thank you.
Thank you. Thank you, everybody. Good afternoon. It's such a pleasure to be with you this afternoon. I will set up my slides. Hope that you see the slides. The first slide is the introduction to the Equity Status Report Initiative for Italy. I'm working at the ISS, which is the Italian National Institute of Health, which is a partner of the program, especially for the role to collecting data. There is a large group of colleagues working on that. The team coordinator is Dr. Bucciardini, and it's an opportunity to thank all colleagues for the contribution to this relevant report. The report, as we said already, is a joint venture between WHO, the European Office for Investment for Health and Development, and the Venice office, and the Italian Ministry of Health, together with the University Ca' Foscari in Venice, the National Statistic Institute of Italy, the National Agency for Regions, and the National Institute for Migration. This is the national level collaborating for the project. Okay. As you may know, the Italian NHS is decentralized to the region. That's why the real contribution is done by the 3 regions participating to this project and program, and also to this webinar. On the left-hand side of the slide, there is an introduction to the Italian healthcare system made by the European Observatory on Health Systems and Policies under the WHO umbrella and with a website for you to go deeper into the Italian healthcare system. About my institute, is the main research institute for public health, and is a technical scientific body of the Italian National Healthcare Service. We are 2,000 staff, 2,000 researchers, and we work on collecting data, producing scientific evidence through research, surveillance, and response to emergencies, from communicable disease to food and nutrition, to health and environment, to non-communicable disease, up to disease prevention, health promotion, and global health. And we have a central role. So the surveillance we do, 31, are about the whole country. And also we have 15 registries of pathologies of national relevance. Obviously, it's a joint collaboration between the Institute and the Italian Ministry of Health to guarantee prevention, data for prevention given to the region, assessment of quality of care and rehabilitation, health planning, but also data on reducing health inequalities. And about the data we provide include the population aging, chronic disease, migratory phenomena, bioethics, environment, climate change, and health and technology, already under the One Health perspective. One of the job and responsibility is also to collect data using the 4 helplines, which are inside the Institute, on tobacco prevention, alcohol prevention, drug prevention, and doping and gambling prevention. About the contribution of the ISS to the report, we are using 5 surveillance system, which are age-related. The first is the children Italian surveillance system in the age between 0 to 2 years. Then we have the surveillance system on childhood obesity between 6 and 10 years. The HBSC surveillance for the age between 11 and 17. Then we have the Italian obstetric surveillance systems. And we have also the surveillance systems called PASSI and PASSI d'Argento, collecting data on chronic disease between the age 18 to 69 and over 69. If I may go too deep for each of the document, the first, the Italian surveillance system for children focus to monitor the health of children between 0 to 2 years, but also some aspects on maternity pathway, such as peri-conceptional intake of folic acid, and also recommended behavior during gestation and breastfeeding, and vaccinations. About the surveillance system on childhood obesity, we collected data for overweight, obesity, and all the related risk factors in primary school children between 6 to 10 years age. And we are also part of the WHO childhood obesity surveillance initiatives. About the HBSC, that's very familiar with all of you, we collected data on risk behavior in school children's age 11 to 17. In collaboration with the University of the City of Turin, the City of Siena, and the City of Padua. About the obstetric surveillance system, it's a really a relevant surveillance system on maternal mortality, which include 15 over the 21 Italian regions. And we produce a series of documents related to multi-regional projects. And finally, the two surveillance systems about the central age between 18 to 65, which is called PASSI. The acronym is Progress on Health in Italy around the local health authorities. And the PASSI d'Argento, we include the elderly, the conditions of the elderly contribution to society, also through paid work or unpaid and voluntary activities to support the families and the community, saying that considering the elderly as a resource, and we are collecting data on that. Obviously we have the 5 policy areas part of the document, and on the right-hand side you see the impact in Italy, especially the difference between the richest and the poorest, which rise at 40% in Italy.
1 minute left.
Thank you. This is the last slide. It's the phase of social and economic impact in the long term. It's providing tackling immediate and negative impacts, equity-oriented actions, which have to prevent the compounding of inequities, and which have been observed from previous economic crises. And now I hand over the baton to the 3 Italian regions involved in the report, in particular to Luigi Palestrini, representing Emilia-Romagna region, and let me add my best wishes to recover from the heavy floating that you were confronted with over the last 10 days. Luigi, the floor is yours.
Thank you,
and
Luigi.
Thank you for your attention.
Thank you, Luigi, and thank you, Bettina, for all your kind words. As you mentioned, we are right in the middle of a kind of severe event, and And I have to say I'm sorry in advance because right after my speech, I won't be able to attend till the end of the webinar. I have to dash off to a new meeting because there's still a bit of an emergency to deal with right here in where I live. And I'll try to share my slides. Let me know if you can see them in just a second. And just I'll take a brief time to say who I am and what I do. I mean, I'm Luigi Palestini. I work for the our regional general management for healthcare and welfare, and I'm the regional coordinator for the governance for health equity in our healthcare system. And I'm not gonna delve into the results of our decomposition analysis and the results of what we included in the Italian Health Equity Status Report Initiative because it's not really part of my job, and I just want to give you some details about what we did with the data that we gathered. Because we started working on data that we collected during the COVID-19 pandemic. And basically we try to understand what happened in terms of health inequities when we had to deal with hospitalization and use of healthcare services. And we found a plethora of results about how the COVID-19 pandemic impacted on, as I mentioned, on hospitalization and the use of services. But what we did with this data, and this is kind of interesting in our opinion, we used it to foster local processes for health equity because we used this data, and not only this data, but we also local data gathered by our local health units to rethink what were the priorities and strategies to gather. So we had to organize and implement a series of workshops with our local health units and the management of such local health units in order to define such priorities and such strategies. And I have to mention this, as a region in Emilia-Romagna, we have a long standing history of using these shared pathways of history of involving management of local health units, but also the communities to define what the priorities for healthcare could be. And we did this not only during the COVID-19 pandemic, but this is something that we usually do in our history. What we tried to do was work with our local health units in order to define not only the priorities, but also to define what could be the actions that could be carried out in order to tackle these priorities. And these actions had to be feasible, had to be accountable, are to be feasible, and they have to be accountable because most of them are still standing, and our units are still working on such actions right now as we speak. And they had to be gathered into local equity action plans. That's how we call them. So this means that every local health unit had to produce a formal document in which they could define priorities and objectives and actions to be carried out. And every local health unit, also has another organizational device, which is called an equity board, which is a group of people who are working for the local health unit, and they usually define what has to be included in the aforementioned the equity action plans, and they're the group that helps the general management of our local and territorial health units to define, as I mentioned, priorities and strategies. And these equity boards have to be redesigned from scratch in order to become something that could be more integrated into organizational processes. And this means that we had to redesign and reconstruct these boards and get them a bit far away from the general management and closer to the point where services for healthcare are produced and from them to the point where the services meet users and the community. I'm sorry, I just saw the question from Cariazo. I'll just give you a quick answer. No, this is something that happens. The equity boards are something that, as of now, happens in our region, and I'm not aware that in other Italian regions there is such an organizational, organizational structure in terms of governance for health equity. By means of redesigning such equity boards, we also had to strengthen the connection between local epidemiology services and the equity boards. And I know it might sound counterintuitive, but in the previous iterations of equity boards, the epidemiological competencies, I mean, the operators that used the workers that used to do data mining and epidemiological data mining weren't always part of such boards, but now we kind of forced our local health units to include their statisticians and data miners into the equity boards in order to, as I mentioned, put together data and actions. As I mentioned before, we had the opportunity to summarize the evidence that we gathered on the impact of the reorganization of our health system during the COVID-19 pandemic. But we also shared some epidemiological findings on the indirect impact of the pandemic on inequality and on hospitalization and healthcare in our region. And we use also some qualitative methods such as focus groups and, as I mentioned, participatory workshops with our equity representatives. Every local health unit has also an equity representative that kind of acts as a gateway between the local and the regional level, in order to define what could be some effective strategies on the regional and on the local level to tackle inequalities. And we produced a bit of information about how we had to focus on the continuity and proximity of care, the digitalization of services, and strengthening the networking on the local level and involving the third sector. But we also had a bit of lessons learned and some more priorities to work on. And as I mentioned,
1 minute.
Yeah, 1 minute. Of course, I'm gonna cut it short. We how can I say that I can say we learned, but we had more evidence about the concept that the epidemiological research and the support to the governance for health equity have to be kept on the same page. We have to keep providing the system with regional and local devices for health equity, both on the research and the governance level. And we have to keep working on this modular approach to the health equity governance, as I mentioned, on not focusing only on the general management level, but also taking the governance for health equity closer to the community and to the users. We also understood that we have to keep all these processes visible in order to foster trust between users and services, in order to keep on being accountable for everything that we do. I think I'm gonna cut it short because this is the main key points that I wanted to share with you. And thank you all for having me here. And I'm really sorry for not being able to stay here with you up until the end of the webinar. I'll give the floor now to Elisabeth Tamanga, a colleague from Regione Veneto. Elisabeth, are you here?
Yes, I'm here. And if you can, I can share. Yes, thank you. Okay. I hope you can see.
I think you just need to put them into the slideshow one.
Yes, I can do that.
Thank you.
And oh, hang on, I need to also go. I think I didn't show myself. Oh. Oh, you will not see me. Okay, you'll see me now. Sorry about that. Ooh. Sorry, I lost 1 minute. That's mine.
We'll let you have a minute back at the end, don't worry.
Thank you very much for this, and thank you for also inviting me to this webinar. We at the region of Veneto region, we did do the data analysis using the Italian Health Equity Status Report, but we also worked together with the multipurpose household survey on daily life aspects. And we carried out, we decided to choose 16 variables for lifestyles concerning alcohol consumption, smoking, physical inactivity, diet, and people with who are overweight and obese. And we confronted also with among the 54 different socioeconomic position variables that were there at the report, with 9 indicators. We selected education, economic conditions, employment conditions, social capital, and the residential settings. What we found was that there was inequalities frequent among all the indicators. They had significant associations with at least one social determinant. So it just confirmed what we already know, that those who have less education, who have a worse economic situation, who are unemployed, have both males and females, they smoked more. The same thing with also with their eating habits, they had worse, inadequate eating habits. Those who had problems with, who had a less education situation, economic situation, unsatisfactory relationships, both in men and women. And among men, there was another factor associated, which was unemployment. There was a difference between males and females regarding alcohol. Alcohol intake was more, for example, for economic situation and working conditions among men, and with housing difficulties among women. Regarding the sedentary habits, it was very similar, both in males and females, regarding also here, education, economic situations, unsatisfactory relationships. But there was a difference. For example, among men, it was associated with unemployment, and among women, it was when they had no social support. So this was what we took from the first analysis. And then we also decided to see what kind of impact the COVID-19 pandemic could have had. And since we didn't have enough data, we did a study of the literature that was there in the years, in 1 year period from February 2020 to February 2021. And also here, what we saw was what I think when many countries saw during the pandemic, our poverty levels increased. There was an increase in unemployment, mostly among females. There was also, we had smart working, but this created, it did help some workers, but it also created inequity, because a lot of people, some types of work cannot be done from home. And this affected mostly, to a greater extent, the categories who were already poorly qualified and couldn't take the opportunity to do smart working from home. And on the other hand, those who started working at home and were isolated, it increased their isolation and feelings of solitude, and especially among the more fragile population. We also saw that there was a reduction in physical activity. It worsened also the eating habits of people, which led, of course, to overweight conditions. There were people who practiced less physical activity, decreased even more, and fortunately, those who were already doing it continue to do so. So this also, we can see there was some kind of inequity, because mostly those who were doing it were also those who had better education situation or economic situation. There was not much influence on the alcohol and smoking intakes, if not for those who already had problems with alcohol consumption. But the smoking rates have very much increased, and especially with the e-cigarettes and the puff bars now among our young people. So unfortunately, we'll have to continue working on smoking prevention as much as possible. And many studies have also reported major changes in sleeping quality. So what can be done? Our region decided to follow the national prevention plan. With the regional prevention plan, it has 6 macro objectives, which includes also non-communicable diseases prevention. And we have, at the moment, 14 programs that we are following. And what the region of Veneto would like to do with the regional prevention plan in the next 5 years is to create and strengthen healthy environments that can contribute to population health by creating networks of health promoting schools, health promoting workplaces, active municipalities, child-friendly communities, and also tackle the inequalities issues and support a gender approach. What we would like to have in 5 years' time is to develop a Veneto model of integrated prevention strategy so that we can take care of all the population starting from birth up till, when 110 years, as we like to say, in good health. One of the instruments that we have created is the Veneto for Health protocol. It's a memorandum of understanding that has been created to support this program, this plan, and it is a collaboration between 20 regional directorates with 10 other external regional bodies, which includes universities, which includes the National Association of Municipalities, cancer centers, etc., so that they would like all these directorates also help with the strategies of the regional prevention program so that we can create health promoting settings and also have impact on the health of the with the community interventions. And we hope that this can be achieved in the next year. So far, what we have achieved is that this Veneto for Health has strengthened the alliance that we had with the school world, which has helped us to develop the health promoting schools network. It has also produced a document of recommended practices where there are included all the interventions at all school levels, which are aimed to promote health and prevent unhealthy lifestyles among students and also their parents and the teachers. We have Veneto for Health has also offered opportunities to create alliances, for example, with the other directorates of the region to promote road safety, and with the regional directorate also of transportation, as well as the regional directorate of environment for air and water safety plans. It has also given the local health authorities the framework to develop local prevention plans for each local health authority. And I have one example of an active municipality, which is we have asked the active municipalities to realize at least one recommended physical activity and one intervention to enhance the urban context to promote physical activity. And what we have done is that the local health authorities have started to contact these municipalities, and we already have some local towns that have been recognized as active communities. And the objective of our region is also to reach by 2023, end of 2023, 20% of our municipalities that become active, and by 2025 to have at least 50% of our municipalities. And another thing that we're doing is also to promote gyms for health, which are gyms that promote health and also physical activity prescription for all people who have particular health fragility. Thank you.
Thank you, Elizabeth.
Okay, I'll try now to get out. I think I have done that. Did I come out? No.
Yes, thank you.
Yes.
So our next speaker is Andrej Slaka from Slovenia. Andrej, would you like to put your slides on and introduce yourself? I'm hoping that Andrej is here.
Just a second. Be there immediately.
I'm sorry, was Lombardia was supposed to be there, for example?
Just a second.
Maybe Elizabeth, if you stop sharing your screen, and then I think Andrej's sharing now. Thank you, Andrej.
Sorry about that. I thought I had already done that because I can't see.
Great, we can see your slides. Oh, they've gone again.
Can you see my slides?
Yes. Yes.
You see them?
Yes, thank you.
Okay, thank you. I'm more used to Zoom than to Teams. I apologize. So thank you for inviting me and for possibility for the presentation. I'm presenting the Slovenian part of the project, I would say, which takes place in a sort of a platform, joint platform. This presentation was shortly prepared, and I will try to be brief. It presents the more of the methodological work that we have done on the Blinder-Oaxaca decomposition, which was shortly mentioned earlier. So this joint project takes place within the framework of cooperation, I would say, of mainly 3 institutions. There is National Institute for Public Health, which is, I think, the coordinator, and 2 further institutes, Institute for Social Protection of Slovenia and Institute for Economic Research, where I also am employed. So another short presentation. So myself, I'm an economist and mathematician. I mainly work in developing estimators and in the mathematical work. So what will be presented is slightly more methodological. It will be briefly and hopefully presented clearly. I would say those are usual problems with more methodological presentations, but please stop me if anything would be not clear. I just additionally verify, do we hear each other? Because I'm not, I'm on a conference abroad. Do we
Yes,
still
we can hear you.
Yes, yes. Okay, thank you. Just to verify. So what we did in this, I was asked to present the decomposition part of these publications that we do. There are 3 articles that I would mention and 3 solutions to methodological problems. So Oaxaca Blinder decomposition is basically a regression decomposition, which means that you can take any, in principle, regression and decompose the coefficients that you get in the regression setting to the influence of the explained and unexplained components, briefly said, as James, previous speaker, I think, was mentioning. So 3 methodological situations that we tackled. One of them was also COVID and the effects of lockdown. Firstly, the first situation, here is unfortunately Slovenian scheme, involves 3 very interesting variables: long-term care, this is this dugotrajna oskrba on the left, healthcare usage, so this is receiving long-term care, receiving healthcare on the right, and on the top, the 3rd variable is health status. There is a clear causal, as you see, reverse causal scheme. If you receive long-term care, this influences your health, and if you are more healthy, this influences how much of the long-term care you need. And the same reverse situation holds for all relationships here, and this situation is resolved in a special panel data model, more related in this case to structural equation, structural causal model setting, but it can be also in other causal settings. And what we did, basically, the basic model includes different variables for long-term care receiving, different variables for healthcare receiving, and different variable for health status. You see them here. Those are the healthcare usage, the health status, and the long-term care usage. We use in 2 of the articles the data of SHARE, Survey of Health, Aging, Retirement, and Retirement in Europe, which counts as one of the very quality data sets on aging in Europe and is accepted internationally. So using the regression, it is possible to analyze each of the coefficients. All of those coefficients that you see is analyzed, each one of them in a separate regression, and using them we get the separate influences, and adding them up you get the full influence of how much does a measure on long-term care influence the measure, say, reduction of costs in health care. And also we use the composition of those regression coefficients, and we get the influences of 4 main variables: gender, age, income, and education. And as you can see here, printed are only statistically significant coefficients, and all 4 variables, I think, had an influence, with age, as far as I can see, gender also here, with high significance. Second article included another very interesting panel possibility, which is allowed by shared data. Shared data is interview gotten data, which is based on the interviews collected in different waves. Currently, 8 waves have been performed on elderly homes. And it is possible because in few waves, in third and seventh wave, the participants were asked about their history. This historical data allows to compose to prepare a special, extremely long data set from their birth to their age of the interview based on their responses, which allows, usually panel context is short in time, but this allows very long panels, live course perspective, and we use this live course perspective, again, decompose the coefficients to get how much to gender, age, income, and education, contribute to this relationship, again, of related to so long-term care, inequalities in receiving long-term care. You'd be able to see here education and gender contributed the most in the explained component and income in the unexplained component. The same holds for any type of informal care. It was slightly different for formal care, where age, income, and education and gender, all 4 variables were basically significant, but income behaved a little bit differently. Finally, third analysis, and then I conclude, analyze the effects of the first Slovenian lockdown on number of infections and number of deaths. As we all know, those analyses were widespread and subject to a lot of possibly even unnecessary debates. What we did is we have taken an econometric model. These effects of lockdown have been, as mentioned, analyzed in many cases. Here you see the basic situation that was happening in Slovenia at the start of the pandemic from March to June 2020. So you see the colors. This is deaths in red, deaths in hospitals, in green, hospitals in light blue, and EQ in violet. So in principle, we wanted to analyze firstly if there was an expected negative effect of the lockdown. The most relevant model was based on one novel econometric possibility, and we have concluded that this lockdown, as you can see here, it started on 13th of March, contributed to about 76% of reduced infections and 58% of reduced deaths. This was again decomposed, and we have found different effects, direct and indirect effects, and again about 40% was attributed to age, possibly even more. This is possibly slightly conservative. Income 37%, and education 23% to in general to these general effects. This is on average for both.
1 minute.
Yes, so basically what I try to present is slight addition to what we also heard earlier, in particular in, I think, James' presentation on the WAHC in their decomposition. So this decomposition can be translated to many different settings, and inequalities in health, we also seen inequalities in long-term care, can in this way be analyzed and decomposed and seen what is the contribution of individual effects. You can see also that some visualizations are popular today for the Slovenian COVID data, and I finish here. This last article will also be presented next week in the Europe Forecast Hub, the setting of the modelers of COVID in Europe. Thank you. The questions are very welcome.
Thank you, Andre. That's very kind of you. Thank you. And now we're going to go back to Italy, to Nadia Vimercati from Lombardia region, who's going to present on schools, COVID-19 and young people, and health promotion in schools network. Thanks, Nadia.
Yes, thank you. I will try to share my presentation. Can you see? Okay. It's good afternoon to everybody. As Luigi Palestini I'm not directly involved in this job, but I'm talking on behalf also of my colleagues, Gelmi and Celata. We belong to the Health Promotion and Prevention Unit of the General Direction Welfare of Lombardy region. As you said, I'm presenting our contribution within the Health Equity Status Report, which is conducted on the school setting, on the young students population. Here are some numbers on Lombardy region, not to comment, just to give a picture, a little picture. Almost 10 million of inhabitants, and then 1,100,000 and more of students, 1,000 and more than 100 schools. And here we have the resources at stake that we have as a health public system for young students. 50% of Lombardy schools participate and belong to the health promoting schools network. And on the right side, you see a list of health promotion programs that are targeted, addressed to young people from different ages. So what we did in our job within the health equity status, Lombardy region participates to the cross-national study, Health Behavior in School-Age Children, on health and well-being of the students, adolescents, that runs every 4 years. And we used the results, the data from the study in 2018, so before the pandemic. And we identified some indicators that you see in the left column that could be related, and they confirmed to be related to some vulnerabilities and unhealthy conditions. Socioeconomic status, type of school, type of family, and migrant status. And as you see, for example, particular type of school, in this case, there were technical institutes or professional schools, they resulted related to more than one of these unhealthy conditions and lifestyles. So what we want to do and what we learned, we want to monitor health inequalities trends by using next study results from HBSG studies. We have now available the results from the study in 2022, so during pandemic, and in fact the study has been integrated with a specific set of indicators to investigate the impact of pandemic on health inequalities on this students population, which we really have. And we also try to, as a system, to support schools through our health promotion programs and tools. So we want to use the next study's results till the study in 2026. And what we would like to do by monitoring these trends is also try to reorient and improve our policies, health programs, and in particular the health promoting schools network as a tool to try to reduce inequalities in these populations. Thank you.
Thank you, Nadia.
I will try to do that.
So I think we've had some brilliant presentations, and for me, they're shining a light. This methodology is shining a light on health inequity. It helps us to understand what the drivers are for that health gap and where we can have the biggest impact. Where we can use this to help drive investment decisions, which orientates those decisions towards prevention. And I think we've seen from Italy that it can be used as a tool, a call to action, I love the fact that they used it to develop equity action plans, and also to capture, I think it successfully captured the impact of COVID on health, linking to health equity and also vaccine uptake. It's also been used, I think Italy demonstrated it's been used to highlight health behaviours that are linked to health inequalities, and also provided us with some examples of how to address them through health promoting schools and health promoting environments. And I especially loved the MOUs, using it as an MOU to have more integrated prevention plans. So I think we can see that the value of sharing our learning from using this methodology, that actually we can use it as a way of getting more action around health inequity and really driving policy change in this area. So I'm now going to open the floor to questions, and I think we've had a question, just going to find it, scroll up, which is for James. There's a question about the decomposition analysis for Wales. You haven't included anything on cost of living or COVID related data. What do you think could be done to incorporate these in the future? Thanks.
Thanks, Joe. That's right. That's probably one of the biggest limitations of our work, actually, is that we ran the analysis pre-COVID. So I guess, yeah, we hear the term of inequalities being exacerbated, don't we, since the COVID pandemic. So there's definitely a need to sort of rerun it to see those impacts. And obviously, as you say, with the cost of living crisis, I think with the work in Wales, I'm very conscious that we ran it on the National Survey for Wales. I'd be quite keen to explore what other data could be used to run the analysis on. We hear lots about linked data these days, whether there's opportunities there, possibly. But yeah, I think rerunning it with more recent data that's been collected in a COVID cost of living sort of context would give some more some new insight, I think, and yeah, for us.
And James, can you just elaborate on how you've used your analysis as a sort of tool for getting action around health inequalities?
Yeah, I think it's been really helpful, actually, in the policy space. So it's identified the levers to sort of pull to make change. But I think we can do more work, if I'm honest, to make it more actionable on a local level. So right now, the analysis has been done at a national level. So, Wales population 3-ish million. I'm guessing a lot of our stakeholders are thinking, what does that mean for my patch? What does that mean for my local authority or, my subpopulation? So I would say we could do a lot more work there if the data allows. Again, this is one thing with analysis, isn't it? We can be great in the conceptual space and think, let's run all these innovative things, but the reality when you may not have a sample size to run something or run something meaningful, at least, presents challenges. So I think we have made some good steps forward in the policy space with actions and with policy colleagues in Welsh Government, but I do really feel like we could do more to make it more meaningful for local stakeholders. I would put my hands up and say we are a bit lacking there.
Yeah, and it's been brilliant having the examples from Italy, which are more on a regional level, and showed how they've done that.
Yeah, just to jump in, I did think it was quite interesting, actually, with the health behaviours, and that got me thinking a little bit about how we could maybe, apply it here to smoking prevalence, for example, between different groups, and if, yeah, it's got my cogs turning, put it that way.
Great, thank you, James. We've got another question in the chat, which is to anyone who could answer. So hopefully we'll have someone that can answer this. How do these analysis and methodologies properly take into consideration and reflect local disparities, i.e. urban, rural, centre, periphery? I don't know if there's anyone that can answer that.
Maybe I can try if it's okay.
Yeah, thank you, Andre.
Basically, but hopefully others can also add. So, I mean, if the question is methodological, I have already put the answer. Two possibilities come to mind immediately. One possibility would be to do the regression, if regression is basis for the, are we online? Do you hear me? There is some.
Yeah, we can hear you.
Okay, one can perform the regression, which is the basis for the decomposition on different levels. Those are so-called multi-level linear models. A second possibility is to include as regression coefficients also regions and decompose then the differences for the regions. Those would be something that would clearly come to mind. So not local linear mixed model that I mentioned previously. So one possibility is to do a type of regression, and another possibility is to include different regressors related to regions in the general Oaxaca Blinder context.
Thank you. I think, Andre, you are breaking up a bit. I think we're getting the gist of what you've said, and you've put a short answer in the chat, so thank you. James, you got your hand up.
Yeah, just to add to what Andre was saying, we could look to do something like this actually in Wales, because we basically offer lower super output area, which is often classified as rural or urban. So where we have defined our two groups currently on whether they're materially deprived, for example, or whether they can save £10 a month or not, we could very well run it with the two groups being, are they living in an urban area or are they living in a rural area? So yeah, I think I'm quite aligned with Andre that it's very doable. Yeah.
Thank you. Have we got any other questions I can't see any coming through. Anyone's got any? I've got one that I think I'd like to ask to Elizabeth, is around the way you've used your analysis to create action. And I just wondered whether you could just elaborate on how you've actually used the methodology to then work with your health bodies to actually, you know, get them to focus in on prevention and health improvement.
Thank you. Well, the analysis that we had just confirmed, you know, what we more or less knew was happening, and it sort of gave a more force to the actions that we wanted to develop. And at the same time, it was also very timely, because we were working on as you saw, our prevention program started in 2020, but actually it got underway in 2021. So this was good, so that we could use this to also involve the other directorates, especially because we are already in health and prevention department, but we wanted also, because we said that health is not only for the health workers, but it also involves all the other actors who live in our country, in our territory, and in the different contexts. So I think it was good. That way we used it to involve the other sections to be more aware of the kind of problems that we are facing, especially in getting some practical actions, especially for the equity issues, not easy. And this was very important for us.
And just a question around, how did you, because I know there's lots of competing agendas at the moment for prevention, and you've got acute problems in hospitals. How do you get that momentum around prevention rather than actual treatment? It's an age-old public health issue for us.
We are always the poorer relative, it is there. We have problems, but I must say that I hope COVID, the pandemic, has taught us something, because even there we found that, if prevention and health promotion was carried out better, we most probably would have had better results also in the beginning. So I think this has, and also for the fact that public health workers were used very highly during the COVID period, and they found certainly that the Department of Prevention actually was very important. And so we are trying also to, how can we say, utilize this, try to use this information, and also the practicalities that showed also to say that if you had, for example, just the fact that if somebody had obesity or overweight problems, they had much worse results also with the pandemic. So this has also helped, and also to the fact that, we also have a national non-communicable disease plan, and this, in the beginning, it was not connected in a way that now that we are trying to connect, that all the public health activities and prevention activities we carried out is not only for some chronic diseases, but it can help really to reduce the inequity issues that is there, especially because we saw the data confirmed that less people are educated, or they have less, for example, temporary jobs are more hard, they're hit more hardly than the others.
Thank you, Elizabeth. There's a question from Lauren in the chat. I'm interested to know what the speakers found to be the most challenging and equally most rewarding, eye-opening aspects were of running the decomposition methodology in their respective areas of work. Well, that's quite a question, Lauren. So shall we go to James first, if we do it in order of speakers?
I think the most rewarding and challenging actually aspect was trying to make the outputs easy to sort of interpret and understand, because when you look at the decomposition, when it's initially analyzed, whether that be through using Stata or R, it's actually quite an unfriendly output that's spat out from the software. So I think, yeah, the most rewarding part for I think not just by myself but the team also was sort of working with that data to make it visual, to try to make it easy to understand. We were very conscious of our audience, was policymakers, so maybe less analytical in nature, maybe needing something that's hitting them in the face a bit more. Yeah, that's probably the most rewarding part for I think us in Wales, really, was sort of having the space to think about how to present the output and results in an easily digestible way.
And I have to say that infographics are excellent that you produced. They're really easy to understand. I think they're really, really useful. So again, something we can share and learn from, with other countries about how to do that.
Yeah, it's a complex, or at least for myself, I find it a complex sort of thing to understand. So yeah, it's good to hear that it is easy to interpret. Yeah, I'll stop talking now.
Thank you. And if we go to Elizabeth.
Okay, actually, I'm not the one who translates the data into more easy to communicate, but I'm the one who tries to convince the people who are working on this data to give me in a simple way so that we can use it to communicate to the others. So what we have done now is in Veneto, we have created a communication plan, actually, which will also run for another 5 years. And we have a team who translates our need into very simple communication campaigns for the population, and also for politicians, and also for our Lord Mayors who are in the municipalities, so that they can understand that even little steps that they take in the right direction and in a intersectoral and synergic way can have impact on the health of the population. So we are trying to do that, and we actually have just recently, last week, started a campaign on movement, for example, on physical activity, and we have just finished one that we had done during the COVID period for vaccination and also for protection of people who were moving, for example, to prevent them from getting domestic accidents or accidents on the roads, which we did together with the Directorate, as I was saying, of Transport.
Thank you, Elizabeth. Nadia, have you got any reflections on the challenges?
Yeah.
Nothing specifically to comment. I don't have answers talking about the methodological aspects of the job, but I agree with the consideration that were underlined, especially about what we could learn because of the impact of COVID that in Lombardy region was very, very high, very. But as Elizabeth was saying, we have a very, very well built national prevention plan with many of programs, health promoting programs that are very cross-cutting, interconnected, and that have to be implemented in all the regions, and with a focus for each plan on equity, so on trying to reduce inequalities.
Yeah, thank you. And we've lost one Luigi, but I think we've still got Luigi Bertinato. Do you have any reflections, Luigi?
Yes, what is coming from the experience here in Rome at the national level, I think the two major challenges we have at the moment, one is called trust, and the second is communicating science. Trust was lost during the pandemic between doctors and citizens because they receive a flooding of informations. Trust was lost because some people, they were not believing on vaccinations, and they were making a lot of shouting without science in anti-vaccination campaign. So trust is a major issue today, since public health, I think the normal citizen, they discover public health as one of the major opportunities within the healthcare system at the national and the regional level. I think they also discovered the role of public health because we provide information and recommendations about schools, how to reopen schools, how to reopen out of schools activities, business activities, sports activities, and the informations were given thanks to data collections we were having. And so trust is relevant, and also communicating science to policymakers. I think your experience in UK was probably different from Italy, because in Italy the institute was providing data to the Prime Minister, and the Prime Minister was the first taking the huge decision to close the country. In your country, in UK, it took some time to convince the Prime Minister at that time. I think it is the fact that data collection on science and scientific activities have to find the proper way to reach and convince policymakers, because then policymakers, they can affect positively or negatively the whole community and the entire nation. I think it's a second relevant public health issue and challenging issue that we have to be confronted. In addition, social media have an impact that have to be considered more than today, by all public health professionals because it's a bit out of control. Each one can get up in the morning and can make a comment on vaccination campaigns, smoke prevention, or other major public health issue. So I think those are the challenges we are having here in Rome at national level.
Thank you, Luigi. Now, Andre's got his hand up. Andre, if I could ask you to be a little bit quick, because there's just Bettina's just going to maybe talk about the next steps now. Thank you.
Of course, thank you. So just to add shortly to previous responses, I fully agree. I mean, today during the pandemic and possibly earlier, some important issues came around, and it will be remain to be seen how also such findings of that were presented will be used. One thing is action that you mentioned yourself, Joe, and other issues, say, related today, we talk about democratization of science. People are more and more involved, say, in citizen science and similar projects, and it will be hugely important how such findings that we presented will be put to practice. And also, we know that in statistics, the development of methodology and similar issues is hugely developing. So how all of those topics will be addressed in future, composed, and probably used for the benefits and for measures development.
Thank you, Andre. Yes, I think we could have a whole another webinar on these topics, actually. So I hand over to Bettina, who's just going to just talk about the next steps. Thank you.
Yeah, so first of all, thanks to everybody and every speaker. Very interesting webinar from three perspectives. First, methodologically speaking, so the different approaches have been used. So there is not really a golden standard because some quantitative and some have more used also qualitative information like focus groups interviews. So it would be very interesting to see on how methodologically, and you made a proposal, Joe, into this direction, this could be moved forward. And for that issue, I would like to propose you to, we have under the Regions for Health Network, so-called solution groups. And this is the type of in-depth discussion, but both methodologically, we are doing. And I'll come back to this in a second. The second aspect I would like to say is that for me, data analysis, data, even decomposition analysis does make sense, even action is followed. And I don't think we have ever had in the last couple, let's put it like this, decade, such a revitalized attention to public health and to prevention. So we need to use this opportunity to really speak out louder. And as you could see from the Italian example, but not only, also from the Wales examples, this is not, you don't take action in isolation. You take action as part of a whole system development. And so therefore, for me, this needs to become a systematic, sustainable, integrated part into public health assessment and public health implementation. Having said this, I would like to invite you all to our next, to the Regions for Health Network annual meeting, which will be held from the 15th to the 17th of November in Andalusia, hosted by Andalusia. And maybe we could really dedicate half a day to what is really now possible considering COVID-19, but also considering the richness of the experiences we have and how could we move this forward as an integrated part of our work. That's what I would like to say. And of course, Luigi mentioned it already, trust is essential, but also knowledge, health literacy, equity literacy, etc., an essential part of building trust and the way on how we communicate. So thanks very much.
Thank you, Bettina, and thank you to all our speakers. There will be a short evaluation of the webinar and the link will be in the chat. And there's also a plea if you want to join the Public Health Network Cymru, we have really interesting webinars on public health topics. And I have to also promote on the 22nd of June at 1:30, we're launching our Health Equity Solutions platform, which Public Health Wales has developed, which is like a sort of one-stop shop for data, evidence, policies and solutions on health equity. And then before you go, if you could, I like to have action after one of these webinars. So if you could put in the chat bar one bit of knowledge that you've learned, something that you've learned today that you didn't know before, and also what you're going to do as a result of coming to this webinar, you know, in your sort of professional life. Thank you. And Bettina.
You know, Jo, and I mean, I didn't do it at the beginning, but because of your Wales action and your proposal, this webinar could happen. So let me thank you and your whole team for getting this activated.
Thank you. Thank you. It's been a very interesting hour and a half. Thank you.